second round of talks going real quick with a summary. I want to try to summarize for you some of the health disparities and national trends in adolescent substance use, to examine how they impact SUD-related emergency room and treatment admissions, and to break out how adolescent trends have been impacted by the larger epidemic of opioid use. So if I look at the substances, you can see here that what we talked about before. If I look at all ages, you can see that alcohol is the dominant drug. And opioid use has been rising, particularly in the last, to levels not really seen since the late 70s. But if I look at it by age, by the substance, I see a very different pattern. For young adults, have the highest and are most likely to be related to alcohol. I look at adolescents, teenagers, they're more likely to be using marijuana than alcohol. They have alcohol, marijuana-related cannabis use disorders. You can see that this is the slide I was showing you earlier, where there's just large health disparities. If I look at it by race and ethnicity, what you can see here is that blacks actually have a lower rate of substance use disorder, and that's not new. Blacks have almost always, through back about 40 years, have always had lower rates of substance use disorders than virtually any other group. It's sort of, there's an odd stereotype that somehow blacks were worse, but they aren't. They actually have low rates of substance use disorders. What you can see here on the other end is that all of the youth have high rates of unmet need, but there is quite a bit of variation across the bottom in the rates of unmet need, with American Indian and Alaska Native having the highest rate of use, the lowest rate of receiving treatment, and the highest rate of unmet need. This is part of why we need the kind of tribal programs that J. Lo is going to be talking about in just a few minutes. If I look at the trends in adolescent substance use, you can see that there are the number of adolescent substance use disorders have actually been declining since about 2012. They hit their peak in about 2010, and the rates of kids with substance use disorders have been dropping, but it continues to be that the most common across that whole time, adolescents have always been marijuana, and this is why some of the marijuana programs are so important, because that continues to be the dominant risk for kids. If I look at opioids and break them out, you do see fairly high rates. The dark bar at the very top is all opioids. The purple bar is prescription opioids, and the red bar at the very bottom is heroin. Kids are predominantly using prescription opioids. When they use them, they're taking pills, less than shooting up heroin. It's also interesting to note that heroin use actually decreased over that period of time. If I look at adolescent emergency room admissions, I get about a 24% increase from 2004 to 2011. And that is overwhelmingly being driven by prescription opioid use and the various types of opioid use, but particularly prescription. This is just adolescent admissions to emergency room admissions. If I break it out again, this is just emergency room admissions. Again, you can see it's being driven by that prescription opioid or pill use, not by heroin use. If I look at adolescent treatment admissions, even though you see there had been a gradual rise in admissions leading up to about 2008, when the recession hit, it hit the adolescent treatment system very hard. And across the United States, most states have retrenched and cut back on their publicly funded adolescent substance abuse treatment. It's still predominantly marijuana, but you can see this rather sharp decline from 2008. Some states it took a little bit longer to hit than others, but it's pretty much happened everywhere. If I look at the opioid admissions, they've gone up, and in spite of all the language about opioids being the high priority, even the opioid admissions for adolescents have also tanked and dropped. Not necessarily because of prevalence, but just because of the cutbacks in the size of the system. So to summarize, the prevalence and pattern of substance use disorders vary by age. There are significant health disparities by age, race, ethnicity, and the rates of SUD prevalence, going to treatment and unmet need for treatment. While the rates of SUD are down, they are still primarily related to marijuana and alcohol. In spite of declining rates of substance use disorder in the community, substance-related admissions to emergency departments are up and are primarily being driven by prescription opioid use. In spite of high rates of unmet need, the number of adolescent treatment admissions in publicly funded treatment has continued to decline since 2008 recession. And with that, I will stop.
Hello, Osio Tahija. My name is J-Lo, the original indigenous male version. If you haven't heard that, yes, I'm here. So I'm from Florida State University, and I'm the founding director of the Center for Indigenous Nursing Research for Health Equity, which is the first of its kind worldwide. In the U.S., there are only 23 Native nurses with advanced education, that would be a doctoral degree, and just a few of us are involved in research. So I think there are 2 of us that are funded by NIH to conduct research. So we are unique. Yes. So first I'd like to again acknowledge the original people of this land, of where we are today. And again, as I've presented previously, if it weren't for the sacrifice of land, lives, and culture, that sacrifice, we would not be able to be here today. And one of the reasons I'd like to do this is I do a lot of work in Australia with our Aboriginal brothers and sisters, and this is mandated in policy. And so maybe we should, try to advocate for that mandate here, that anytime there's a public forum that we do acknowledge the indigenous and original people of that area. So I pay my respects. So our people, and I am guided by lots of folks in our communities, and one of the emphasis that they say, the youth must be our focus. We have to, if we don't save our youth and address and work with our youth, they are our future. And so what we're guided to really approach is to ask the youth, who are you, where are you, and where are you going? If you don't know who you are, you don't know where you are, you certainly don't know where you're going. So that has become the kind of the driving questions and the driving guiding force behind of what we do in addressing adolescent and youth substance use among our group. As you probably have heard today, here's some data about what our use is, what is known. There's not a lot known, but most of it does come from the National Survey on Drug Use and Health. And so, of course, you can see the rates there for our substance use rate, especially among 12 to 17-year-olds. But for us, what about youth 10 to 12-year-olds? And so that's not really known there's not a lot there, but about it. And so our communities and the work that we've done, most of the communities, leaders, etc., and even the high school adolescent group said, go younger. You've got to start younger with preventing and intervening. So this is a little bit what's known with 4th to 6th graders, and the blue line is American Indian or Native rates. And so you can see, without going into all of the ones, but especially the marijuana, which has been talked about, some of the others, you can see it's pretty high. So our youth usually starts initiating substance use around the age of 10 to 11, and then it's higher than most other groups. So why the reasons? Well, there's usually in our communities, youth younger. There's not necessarily a separation between younger and older groups. Many times we socialize in a different way, and so in a closer way. And so one of the things is that so we're influenced. Our younger are influenced by the older group, and sometimes even what's happening in families and communities. So there is always a reason, and And our elders usually mention to us that we should really talk about, to understand who we are today, we should talk about and talk about what happened to us historically and who we were in the past. So of course, without going into too much details because of a time restriction, historical trauma is something that we pass on intergenerationally. We had forced removals, we had boarding schools, and all of the other things that come along with it. I would like to share with you one little, piece of information and talk a little bit about this. And probably across the world, in most indigenous countries and areas that were colonized, the boarding school or residential schools was one of the things that was implemented, and it just did so much destruction with our people and communities. And so this is a real famous picture. So when I was doing in the early 90s my doctoral work and developing what we do today, I went and I wanted to get the story and capture really what that was like. I did not have to go to a boarding school. Like I said, my father never went to school at all, so he escaped that. But his oldest sister, my eldest aunt, went to a boarding school. And I showed her this picture. She was 92 when I was doing my work. And I went and I showed her this picture and I said, Auntie, what does this speak to you? What does this mean to you and your experience? And so she took a while, and it took several days for her to really share her story with me. And at 92, she still could not, it was still very painful for her. And many times we had to stop, she had to cry, and it took days. But that was a gift. If you're ever have the honor and the privilege of being able to interview and to talk with folks and our elders in whatever community you're connected with, it's an honor to get that story and for them to share with you. And it really adds to that whole passion about doing what we do. But she pointed out this little girl here, this one. You see, she's like this. And my auntie said, see, children supposed to be happy. And no one, she said, was happy when they were at the boarding school. You see how they're all uniformly dressed. They were stripped of their culture. And she also explained that they had to come out every morning and be counted. And the way they counted was 1 little, 2 little, 3 little Indians. They had to count off. And that's where that song came from. So, of course, many of us grow up and people sing that song and like it's just a real nice little song that children sing, but it has deep-rooted meanings. And so she talked about that because if there were supposed to be 100 kids and they got to 99, they knew one had run away and escaped. And she tried several times to run away. So it gives context for why we have some of the issues we do. And then a real popular and a scholar and a researcher that did a lot of work, Dr. Fred Buvet, did a lot of work on alcohol abuse among American Indian, Native American substance use, and especially in alcohol. And he came out with, after reviewing, that one of the things was the loss of culture and not a way to be able to measure cultural factors was an issue for our youth, and so something we need to move to. That really gave me an inspiration when I was doing my early work, in that we needed to have Native-driven, from our culture perspective, somehow a model. There's a lot of models we're asked to do if you're a student. You've got the health promotion model, and you've got this model and that model, but it doesn't necessarily mean that it has relevance to our culture and our people. So I like to use the circle that, most of the models that we use are that outer circle, non-native, and then there's some real generalized ones, and then there's the cultural specific ones and tribal specific. So I started with our group, Cherokee, and we came out with a model from lots of different studies. It's called Cherokee Self-Reliance Model. Then it moved to Native Self-Reliance. And now it has evolved to be just Native Reliance, because many people were getting the whole word self was kind of referring to individualism, and we're really a collective group. But self, the way we define self, is not just this, it's everything we're connected to. So that's our families, our communities, all of creation. So now it's evolved to be native reliance. And we have a tool that we measure for the concepts, and that has shown some great reliability. And so another model that we have developed is called the circular model for cultural tailoring. And so this is a way we can tailor different models, and especially like the native reliance, to be able to be used and adapted for different other tribal groups and indigenous groups. So we developed what's called the talking circle intervention. And this is an intervention that is a 10-week, it's manualized session for Native and Indigenous youth. And we are now in the U.S., we're in Australia working with Aboriginal youth, we're in Canada with First Nations youth, soon to be in Panama with some Indigenous groups. We've tested this in many, many ways, and one of the ways that we've tested it is using a randomized trial approach. And we've tested it against where some youth would go through what's called the DARE or the Be a Winner program, which we know doesn't work for our kids. And so the talking circle is very cultural based, and the approach is very different, and it's done and delivered what we refer to as a talking circle. And we use different measures for substance use, for alcohol use. We just developed a new alcohol use for measure, and it's called the AMI, the American NAMI, Native American Alcohol Measure for Youth, NAMI. So because there's just not any really available. There's a few, but not many. So that's alcohol specific. Just to show you a little bit of the results, the native reliance, you see what happens. The blue line is the talking circle intervention, whereas the green line is the other, the standard, which is usually the DARE, Be a Winner. And you see what happens even at baseline. They kind of start the same level with cultural self-identity as a Native person, and then post, and then you see where it goes afterwards. And we've even done some a year later for just to get a little bit more longitudinal results, and it stays up even post. And if I had time, I would share with you why we think that is, and you can ask me later. And I've had that interpreted through our elders and other people from the different cultural groups. And you can see the substance use scores. Usually the blue again, the substance use and substance involvement goes down and stays down usually after going through the sessions. Stress, this is very interesting. This was an earlier study where stress, you see where it went down, immediate post at data point 2 here, but it then 3 months later went way back up. And so we paid attention to it. They weren't using, but the stress went back up. So we redid some of our intervention sessions to focus in on the stress. And so what happened was we, after paying attention to it, then it started going down and staying down. And we had to really pay particular attention to the stress, which makes sense because, you know, there's a lot of stress in our communities and so forth and so on. Our youth were experiencing it. So now we're in the middle of, we're actually in year 4. Dr. Baldwin is a co-PI with me on this study, and we're now using the talking circle intervention virtually. We're testing it using a randomized approach. And it's real exciting because we have 3 different areas in the country with tribal youth, and they come on and they do the sessions together virtually. And so, you know, and our youth are connecting to this very easily, and they're very much more technologically, you know, inclined than what we thought. And so it's real interesting for them to share, you know, somebody in the southeast to somebody in the central northwest. So that's been really good. Wado, thank you.
Well, good afternoon, almost good evening. My name is Kathleen Moore, and I am faculty member in the Department of Mental Health Law and Policy. And I want to acknowledge Vanessa Tate and Lauren Julian, who worked on this project for the past year and a half. We were able last year at this time to present some of the qualitative data, and so this year we thought what we'd do is talk a little bit about some of the preliminary quantitative data that we're just starting now to analyze. And so this is just the preliminary stages, but I would appreciate any discussion that we can have about some of these results as well. So just an outcome evaluation of our Adolescent Marijuana Delinquent Act citation program that is being done in Hillsborough County. Just a little bit of an overview. Juvenile civil citations are an alternative to arrest for common misbehavior for youth under the age of 18. And youth can take responsibility for their actions and complete a program that can include the following: community service, letters of apology to both the victim and law enforcement officer, assessments to determine if the youth are at risk to reoffend, and then, if needed, an intervention service such as counseling, both individual and group. And there's a lot of data to support that these juvenile civil citations generate positive results, such as increasing public safety, improving youth outcomes, and saving taxpayer money than arrests for some of these common youth misbehaviors. So what our state attorney, Andrew Warner, did is, let me get it, Warren, sorry. He has a short 2-minute video that talks a little bit about this. So just a little bit of background about that. So when we came on board a little bit before then, the previous year, we were asked to evaluate the Delinquent Act Citation Program. Now it's fully within the Juvenile Civil Citation Program, but they wanted to get a little bit of information and evaluation about how the program was working. We already have about 9 civil citations within Hillsborough County, and so possession of marijuana and drug paraphernalia would be the 10th new civil citation. But we were able to kind of go in at the beginning and see how this program was working. So how DAC originally worked was that an adolescent was caught with either marijuana or drug paraphernalia, and they were determined if they met eligibility. Parental consent was then collected in person, and then the adolescent was referred to the DAC program, and they had to fill out paperwork by the end of the officer's shift. Then court came into play, and the adolescent had to report to juvenile diversion within 24 hours of referral. What we found was that this was a really quick turnaround time, and so we reported back to the team that if they could extend that to 48 hours, that would allow for the officer to get that paperwork to diversion and allow for the child and the parent to come in together. The initial assessment was given at juvenile diversion, and then they determined a level of supervision. And that was either with juvenile diversion, and that was low, medium risk, or if the child was deemed high risk, then the overlay was juvenile drug court. And then the location of treatment was really determined by where the child lived. So we have 2 treatment providers, DACO and Phoenix House, and so depending on where the family was, they would either go to one of those 2 treatment providers, and they were providing the same type of treatment. And then treatment, the adolescent then had to report to the treatment provider, and a pretest was given with the initial assessment. And then a level of treatment was determined depending on treatment duration. So if it was a low-risk child, then they may be done in 2 or 3 months, and it was more psychoeducational. But if they determined that they needed a little bit more time, then they could go up to 6 months. And of course, they were always, if they relapsed or went back, they could always go back and extend that period of time. In addition to the treatment, which included individual and group counseling, they also were required to do 1 to 2 random drug screens a week, and then also report to either juvenile diversion or drug court, depending on the overlay. And then successful completion results in avoidance of that child's arrest record. So the evaluation was twofold. We did a mixed method, a qualitative portion that was discussed last year, in which we interviewed 15 to 20 key stakeholders, and then we also collected 55 pre and post tests from the adolescent participants that we're going to be discussing today. And again, we just started getting into this data, so I'm going to be sharing with you some of the demographic characteristics and some of the preliminary outcomes. But the assessments were given during the first and final meeting with the treatment provider, so pre and post. We created subscales using the GAIN-Q and the TCU, which is the Texas Christian University Adolescent Forum, which I'm going to be reporting on this afternoon. The assessments were de-identified by the treatment staff before being returned to us. So we did not know the person's name, we just had their ID number. So a little bit about the baseline demographics. A referral could be given either in the community or at school, and you can see overwhelmingly that most of the referrals were given by the school resource officers. All of our schools have a resource officer in middle and high school, and so 83% were given a referral in the school. The status, and this was of January of 17, where we had quite a few active clients still. So we're in the process of going back to juvenile diversion to gather that information so then we can assess how many completed and how many failed to complete the program. Some of the adolescents in the beginning of the program either declined, were ineligible, they had other charges, or they denied that they were actually, they actually had the marijuana on them. The assessment score, you can see that most of those are scoring low, 78%, and 22% scored medium or high. And this was done using the GAIN-Q. Some of the baseline characteristics of the client, we had 70% male. You can see that the mean age was 15. We had quite a few 12 and 13-year-olds, so those are coming from middle school. I think we had 25% middle school and 75% high school. The race, we had 64% Caucasian, 27% African American, and then Hispanic, we had quite a few endorsing being Hispanic, 42%, and then 58% were not. So what we were able to do is look at some of the TCU adolescent forms, and so they have various different subscales. And what we found were some significant changes from pre to post test overall when we looked at all 55 kids. And some of the scales that were significant were drug resistance efficacy, assertiveness, and cold-heartedness. So what does that mean? So drug resistance efficacy states, I am confident that I can find ways of reducing stress that don't involve alcohol or drugs, avoid situations and people where alcohol and drugs are present. So they feel better able to do that. Assertiveness is, I'm confident that I can express my opinions when others disagree with me. I can say no when I need to. So they're not really apt to follow peer pressure. And then cold-heartedness, so this is reverse scored, and this was, you worry when a friend is having problems, when seeing somebody cry makes you sad, so they are feeling less cold-hearted, right? So that's reverse scored, which is good, right? Our kids are having some empathy. We also found some family and peer significant results. Peer family is that your family actually likes your friends. So there, a lot of times kids are hanging around those kids that they really didn't need to be hanging around. And then after treatment, you know, they're really told, you know, you shouldn't be hanging around, you know, Johnny and Sue, but now they're hanging around some more positive friends and they're doing more positive social activities. Peer socialization was almost significant, it was 0.06, and so it just kind of is the same kind of story where they're doing things that are socially acceptable and they're not hanging around kids that are using drugs. Because this talk is multicultural, we wanted to look at some of the race and ethnicity results as well. And because we had a fairly significant portion of our kids that were self-identifying as Hispanic, we were able to break up Hispanic and non-Hispanic. And what we're showing here is two results, peer family and family warmth. And you can see we have pre-test and post, right? So the yellow is the non-Hispanic, the red is the Hispanic. And they were fairly similar at baseline, but you can see at post that Hispanic kids are endorsing more peer family items. So they're feeling that their family is more comfortable with their friends at post-test. And then family warmth, those items are your family often sits down to eat together at the same time. You have family who make you feel loved. And you can see there's a significant difference at baseline between Hispanic and non-Hispanic. And then at post, this was not significant, but this was. So you can see that Hispanic kids are feeling more family warmth, right? They're feeling more of that together time, which is significant. So we want to delve into this a little bit more, but again, I just want to show you some of the preliminary data. So what does this mean? So preliminary findings suggest that youth are showing positive change over time with the DAC treatment program. They felt more assertive and confident that they can say no when they need to in terms of risky behavior and drug use. They develop more empathy toward friends and people in general. And that the ethnicity findings demonstrated that Hispanic youth significantly increased their endorsement for both peer-to-family and family warmth, and they felt their family accepted their friends and loved them upon completion of treatment. So some of the implications and future directions of our program, the goal of this treatment program is for youth to remain clean and sober, to engage in pro-social activities, and to re-engage with their family and peers. So our preliminary findings suggest that treatment is indeed effective, but additional analyses are warranted. And we want to continue to analyze these findings in terms of gender, race, ethnicity. We want to also look at risk levels, low versus high, and we also want to look at treatment duration, because some kids were able to complete treatment in 2 to 3 months and others 6 or 7. And we want to look if there was a difference between low versus high. Also, we want to examine the black box of treatment, right? So treatment mainly was looking at motivational interviewing and CBT. So we really want to kind of break that apart and look at drug use, look at criminal thinking, look at peer pressure, and look at treatment needs. So those are some of the things that we're going to be doing in the next couple of months. And that's it.
I have one question. So how did this, I know from talking to Naka that like suicide and depression is also a problem in Native American communities. So I was wondering how this could affect like that.
You know, a lot of things are cofactors, and I think that's what, you know, one of the ways to address the suicide. But also I think it gets again back to the context of the trauma, and there's a lot of, you know, science has moved us to helping us to understand historical trauma, genetic memory, et cetera, how things get triggered. So I have a way I deal with youth, and especially where I'm from, but so I sometimes ask if it's, especially the young, I love it when the younger are in the room, and I say, the bear shows up, what do you want to do? And so they go, yeah, we got to run, and it's really the wrong thing to do, but so if bear shows up, you know, you should really make a lot of noise and so forth and so on. I think it depends on the type of bear too, but yeah. But so then so if the kids say they want to run, then I ask them, how are you going to be able to do that and run fast enough to get away from the bear? So one of the things we talk about is that Creator gave us in our bodies a community of members called organs. And so those organs sends us the help we need. So one organ system sends us cortisol. One sends us adrenaline, gives us lots of energy. Glucose, the same thing. And some of the other substances that we know all the organs do. And we go through, and so that we can get away from the bear. So if you want to stay, you want to fight, we say that's fighting. If you want to run and get away from the bear, we say that's flight. Fight or flight. So we go through that system, you know, we talk about what that means, and that what our community members in our bodies help us with. But then we start talking about what is the bear and when does it show up. And so we get into thinking about the bear is maybe the bully at school. Could be a teacher that might have said something off, you know, about who you are, about your community, etc. It could be mom and dad coming home in a bad way to your home. It could be lots of things. It could be that maybe you didn't have anything to eat yesterday or last evening or this morning. And that certainly happens with a lot of our folks. So, and then we talk about, it could maybe even be a memory that got triggered, and it could be from the past and what that means, etc., because we know that if it's good to have these systems in place to be able to help us when we need it, but if we go through that response 5 and 6 times a day, it's not healthy. You know, it takes cortisol 8 hours to absorb. and we know that it blocks insulin uptake. We can't utilize insulin the way we should. And at the same time, so you have that cortisol raging and you're having lots of glucose coming out to help us. So it's a whammy, it's a double whammy for us. And so if we go through that 5 and 6 times a day, and so we talk about all of that, and I forgot what your original question was.
Suicide?
The bear showed up.
Depression
didn't
and
it?
suicide.
Oh, the suicide. So some of the issues. So I think I'm giving you context for, I think, suicide is also included in all of that, and why we become so helpless or we become so anxious, etc. It's that fight or flight possibility. So does that answer?
So I had one question for any or all of you. The schools are kind of the foundation for where youth interact with adults, and it seems that schools have a tremendous potential opportunity to make differences for youth regarding substance abuse and mental health services, of course. But for substance abuse, I don't think the schools are really doing what they can. I think they're beginning to understand the importance of mental health, but not so much substance abuse. And I don't know if that differs in different settings, but perhaps you can, any or all of you can speak to the issue of the schools.
Yeah, I would just say, like, I had that exact, conversation with our SRO officer. My daughter's at high school, at Blake High School now, a public performing arts school, and I asked that question because I wanted our local anti-drug alliance to be able to collaborate to come in and do a prevention talk. And it's really difficult to get involved in the schools because these kids have so much going on, and for the SRO officers, I think they do something, he said, with the juniors. But you were talking about 4th and 5th graders, right? Starting to think about smoking pot and drinking alcohol. So we really need to do it not starting in 11th grade, but really early, 5th, 6th grade. And I think we need to do a better job of connecting with our community partners, with our schools. But it gets difficult to do that sometimes because there's a lot of barriers. And so I wish we had more openness with some of the schools, because I wanted our SRO officer to actually talk to our alliance, but he couldn't do that because he had to get approval and all of that. So, but I think as much as we can have that conversation and keep up the open dialogue, it's a start. Did you want to say something?
I just have a question. Everything that you all say about marijuana is absolutely petrifying, and yet state after state, we're moving towards, recreational marijuana, medicinal marijuana, and stuff like that. So I'm just trying to figure out, like, what should we be doing in our role to kind of make sure that we're doing the best protection that we can for our children, knowing the changes that are unfolding in our country around marijuana.
As a parent?
Well,
As a provider?
as
As a citizen? Yeah.
people that are in charge of kids' systems of health.
Yeah. It's a great question because I see the perception changing. I see it shifting. I think we need to, like I said, keep the dialogue open and keep our kids, they need to understand, adolescent, what goes on, and to converse with them. When they start to, because I think their depression is rampant among some of these kids, and so then they start turning to alcohol and marijuana because it's accessible. And if we legalize marijuana, then it's going to become even more accessible. So having that dialogue, and I think, I talk a lot with our SRO officer. I think parents that, can go in and have that conversation and attend some of these, our community, every community has an alliance. And I think we need more parents so that we can all talk together and start earlier. So we're not starting in high school, we're starting in elementary and middle school.
I wanted to go back to the question about the schools. So one of the things that I didn't get an opportunity to share with our project, the virtual talking circle intervention. So we are scaling it up, and one of the things we're doing is, and we completed, is an adult training in each tribal community so they could continue it post And that's part of that sustainability, that implementation piece, and the scaling it up. So they are trained and so forth, and so doing it. What we discovered was that in many of the tribal communities, those adults, and these are teachers, mainly teachers, and some are, boys and girls clubs, facilitators and counselors, etc., that when we put them through the training, we had to kind of go a step further. They had to go through the sessions because they have the same issues. The same issues, especially if they're tribal, and they have the same historical trauma, etc. So who do the children, the schools, when they come to schools, they interact with the folks who have the same issues, probably more pronounced. So they all need it. So the teachers who are working every day in the schools. So in order to make schools, I think, healthier and also being able to intervene with our youth, they have to have, and probably acknowledging that they have these issues because they don't know how to deal with these children at all. And because they're dealing with the same issues themselves. So it was really an interesting finding. And so probably we'll do another study and propose to just deal with teachers.
I just wanted to get your opinion on this. So I feel like all students, every year we're studying history, we're studying English every single day. What are your feelings on implementing something like behavioral health education and like different coping skills and whatnot in school every single day? Because that's what we're all struggling with. I just wanted to get your opinion on that.
It's a great question.
Yeah, it's a great question. And it's challenging because schools the resources now are so limited, and some areas are really small. One of the things that we've done is we've advocated, if schools have a choice and if they have tribal youth, and even not just tribal youth, but why not use something that now we have great evidence that demonstrates it to be effective instead of using these other and paying for other things. And so it's an advocacy role is one thing.
There was a great, you had Surgeon General Satcher speak to the students a couple years ago. And he actually, when he had a thing where he had a whole thing on co-occurring mental health and substance use and made the point that why aren't we teaching mental illness? When you've got kids rampant with problems, we're not teaching mental health, we're teaching mental illness, if at all. But he was talking about wellness and screening, and that we screen for polio and all kinds of relatively rare things, and then we don't screen for the common things that are rampant in the community. And we don't teach the coping skills. And it's still a good read. As a Surgeon General's report, but he had a pretty proactive arguing to be in schools, that there should be school-based health, school-based behavioral health, that we should be doing wellness and other things.
Right.
It also speaks to what we talked about yesterday, why we need to look at cultural determinants of health, strengths-based again.
Yeah. And that's
Instead
what
of
he was
just social
advocating, that we should get ahead of it.
Right, we don't. And I think that's why we have then kids, when they leave high school, then they don't have these skills, right? They don't have a lot of skills that they need to enter college. And, we're just throwing them out there. So I think that we should be doing more of that. But again, it is hard to infiltrate into the high schools. If we can do it at a lower level, then by the time they get to high school, they may have their tool belt that has a lot of these skills already in place. That's what I think we should be doing. But prevention, the monies for prevention are becoming less and less. So there is a funding issue as well. But again, like I said, we have a lot of community support, and so to really rely on your community to help engage that, and the parents too, because parents want to help, they just don't really know what to do.
John, do you have one last question?
Yeah, just one last question. Since y'all talked about limited resources, because this kind of comes into my next question. I know that DACO and Phoenix House already get like a lot of people from the Marksman Act. And with juveniles coming from the new Citation program, what are we doing to increase the resources for those people working in those facilities to back away from burnout and stuff like that?
Well, I'm working up with DACO right now on 2 grants, and so that's what a lot of times they work on. They work on external grants, so they do get county and state funding as well as some funding from DOC, but they do rely on a lot of grant funding as well. So we try to, right now we're working on a minority aid initiative and then one for homeless SMIs, clients with severe mental illness. So there's different populations that they focus on. But for juvenile justice, there is limited funding, it's true. And so we don't have a lot of residential beds. So most of the treatment that these kids are going through is outpatient. So if they really need a higher level of care, there's not the resources needed for that. So that's definitely a need.
All right, well, I think we're about time.